Okay. So, good evening, everyone present here, and all the participants and the audience watching all. So, Dr. Gagandeep Kaur, welcome you all to Global Interdisciplinary Summit 2020, co-hosted by Global Outreach Medical as well as Health Association. So, moving on to the session of the day, we are having Dr. Kim with us. Okay, so Dr. Jin, we're having the session from Dr. Jin right now, and I would like to guide all the participants to fill the registration form, which will be there in the description box, as well as you need to add a screenshot of the session, which will be acting as the proof. And for further updates for the participation, C certificates, as well as the speaker's schedule, you can all log into www.gomha.org. So with this, I would move on to talk about Dr. Jin. Dr. Jin is a board certified periodontist with practices in South California. His formal training includes dental school at the University of Sydney, Australia, specialty residencies in periodontics and implant surgery at UCLA Medical Center, and he holds advanced degrees in pathology, public health, and oral biology. He is a fellow of the American College of Dentists. An author, lecturer, and educator, Dr. Kim teaches and advances his chosen field and has lectured in 36 different countries. He holds a number of faculty positions in universities across the globe. He directs advanced life surgeries training programs as a director of GDIA and has founded the West Coast Dental Implant Study Club. In his spare time, he serves as an assistant scoutmaster at Troop 93, Boy Scouts of America, and is an avid home brewer. He is a diplomate in American Board of Periodontology, American Board of Oral Implantology, International Congress of Oral Implantology. He's a fellow of American College of Dentists, American Academy of Implant Dentists, and even I would say words are quite less to explain about him. So I welcome Dr. Jin, the speaker of the day, to us. And sir, the stage is all yours.
Thank you very much. This is very, very exciting. Do we have the screen on live now? Okay.
Yes, so you can start sharing your screen.
Okay. Should I start?
Yes, sir. Yes, sir.
Okay, thank you very much. This is a great privilege and a very unique way of meeting people around the globe. I have traveled extensively, visited many countries, and sharing what little I know about implants and periodontics and my passion of dentistry. But this is very, very unique and how we can all come together in these unusual times. Here's my family, my beautiful family, and all the things I do. Today we're going to talk about anterior magic. You know, anterior implants are not the most easiest things, so we want to see what kind of tricks do we have. This is what happens one morning. Sunday morning, I'm trying to sleep in, having a great weekend, and this pops up. Initially, I thought it was some sort of a prank. Did one of my friends send me just for laughs? And then the notes followed. This is real. This is one of our patients. Come in. We need to see this patient. That was a Sunday morning, a rude awakening. This poor gentleman was beaten up the night before, ended up in the emergency room, and the resident on call did her best to put everything back together. But he's a person of social status, and he needed something much better than that. Than that. He needed to be on camera on Monday. So, what tools can we pull out of our toolbox? That's pretty much, what our dilemma is. By the time I ended up going to the office on that Sunday morning and inspected, this is what actually happened. The splinting done with good intention, when it was all checked and evaluated, was not very stable and adequate. By the time I removed it, actually 2 teeth ended up being lost. One was already lost at the emergency room. The other one simply wasn't stable enough. So here we are, Sunday morning, not well prepared, 2 teeth missing. What do we do? So when we open the flap, we see a significant amount of the buccal
Sir,
bone
sir,
plate has been removed.
sir.
Yes.
Sorry for interrupting. Actually, you need to share
Mhm.
your screen. It's not there. It's not visible to us.
You're the one that shared the screen, wasn't it? Did
No,
we?
no, no. So we are not having any screen shared right
Nothing.
now.
Nothing. Oh, you want me to start over then?
Yes, sir.
Okay. Well, yeah, I wish you would have told me earlier. Let's start. Let's start. Um, share screen. Share screen. There you go. Can we see it now?
Yes, sir. That's totally perfect.
Okay. Well, try number two. Well, this is my family. I have a dental family. My wife is a dentist. My oldest son, pictured here in the purple shirt, he's in dental school currently. At home though, he's actually going to school in New York, but he's actually home. And the two other boys, we are. Let me see why this is not working now. Okay, anterior magic. What can we do? Anterior area for implant dentistry is a very, very challenging area. And despite experience and so on, we're always needing extra tricks that we need to be able to pull out at once to be able to handle unique situations. This was a text I received one Sunday morning when I was sleeping in, calm Sunday, and all of a sudden this text comes in. And I'm saying, wait a minute, what am I going to do with this? Um, I was called into the office, and when I entered the office, the history was that this gentleman was physically beaten up the night before, ended up in an emergency room early hours. And the oral surgery resident on call basically had to put together things in a hurry. So, this is the way the gentleman presented to the office early Sunday morning. No assistant, myself, and one of my partner doctors. And we're looking at the patient and thinking, gosh, how do we handle this? This was a person of a pretty dignified public figure. Monday morning, he needed to be in front of all sorts of cameras and whatnot. So we need to have a toolbox where we're able to pull out the appropriate tool in times like this. I inspected the splinting, and by the time I cleaned things up and removed the splints and whatnot, I realized that two centrals were victims of this trauma. One was already removed, and the second one was about to fall out. So we have a situation of two central incisors missing, and when a full thickness flap is raised, you can see the buccal plate has a significant amount of damage. So, what do we do? This I felt was an ideal situation to put immediate implants because of many factors, but let's walk through. The two implants were placed in the ideal three-dimensional position, which I'll go into a lot more detail. And in summary, it should be slightly palatal. There should be appropriate distance between the teeth and the two implants, of course. Chairside, I made a pretty rough, customized healing abutment, CHA. Now, these could extend and become provisionals, but in this situation, stability wasn't that great. So I made it a flush gingival level. And as you can see, the stainless steel wire was then used to put together the extracted teeth crowns as a very desperate provisional restoration. What you see now is a very thick layer of sticky bone and platelet-rich fibrin, PRF, or some of us call it CGF, concentrated growth factor. And this is almost a protocol today. Remember, this was almost 10 years ago. This is a paper that our group wrote in 2015 describing what is very well known today as the sticky bone. Sticky bone is how we bring together the bone graft materials to incorporate growth factors by using the patient's autologous platelet concentrate. So here we are. After a small time, the patient was packaged together literally so he can go back to normal life, to normalcy. Now, notice that the two centrals were out of contact, which is really ideal because that actually helped us a lot. This is clearly not immediate loading. This is immediate provisionalization. A month later, pretty decent amount of healing. You can still see some scarring, but volumetrically, we haven't lost a significant amount of tissue, which is a great thing. And at 18 weeks, we are sure that the integration of the implants have happened, and some primitive form of papillae and cold tissue seems to be evident. And now is the role of the restorative doctor who is going to carry this case, groom the case, and eventually make the appropriate restorations. And this case was done pretty decently with the patient satisfaction by my partner, Dr. Nancy Yi in Santa Monica, California. So where are we today? Immediates is clearly one of our main tools. Immediates, meaning immediate implant placement into a extraction socket, which is, it needs to be done with caution. Immediate provisionalization, just like how we saw, it can have a full contour restoration, or in this case, a small unloaded situation, immediate function, or true immediate load, as in all on four types of restorations, which is becoming done more and more often. Now, this is an old joke, but I have to throw this one in. All implants in my office are done as immediates. Now, in normal circumstances, in audiences, we get a little bit of a reaction immediately upon payment. So in my office, every single implant is an immediate payment, immediately upon payment. Anyway, old joke. So utilization of biological enhancers, as you saw, the sticky bone, using platelet concentrates, using it in a flat, what most people call the membrane or pressed form, has many, many advantages that we are seeing broadly today. We have to fully understand how soft tissue behaves and some of the surgical techniques and skills involved. John Chow gave an excellent presentation this morning, and the pinhole maybe is not the appropriate thing for the implants, but the concepts there are quite valuable. Utilize root banking, partial extraction therapy that's becoming very popular in today's world, and to provide good amount of bone, because at the end of the day, the implant is there to be lasting pretty much the patient's lifetime, and the crystal bone, the good amount of volume of crystal bone is clearly important. Another old case of mine, Christine. Young woman with good gingival display and trauma to the face, volleyball accident many years ago. Heroic dentistry was performed, yet the tooth had to go. The tooth came out without much resistance. You see, there's no functioning periodontal ligament anymore. It's just thickened, scarred secondary tissue, fibrotic granulomatous tissue just in the way, which unfortunately has to be all cleaned out, and we are attempting guided bone regeneration in a classic sense. We want new bone, new tissue to grow in there so that soft and the hard tissue will be ready for us to provide the dental implant restoration. We went to the patient's palate and utilizing the subepithelial connective tissue graft. I was able to harvest a very large piece of tissue because of the sheer loss and lack of the soft tissue volume. You can see a PTFE type of membrane there, carved and shaped appropriately. Releasing of the flap is crucial so that advancement of the flap and minimal amount trauma, minimal amount of pressure and tension has to be built in. And at the end of the day, all of that was put together. The patient was put in a removable provisional restoration, and the patient then leaves after that. Now, being a young lady, she really didn't like the fact that the tooth are shorter, but that's exactly what we need to do. And I convinced her that's the way it has to be. Well, she left my office, went straight back to the general dentist's office, and somehow sweet talked him into giving her a full contour. And of course, the next time I saw her, I said, sorry, I can't do this. And I had to put a bird to it and cut it away, because we just cannot allow external forces to interfere with the healing. this is a first healing after the first surgery. You know, what we need to notice is the fact that there's good closure and the fact that the papillae on both teeth are pretty decent. Now, the facial contour is not ideal, of course. And next time we go in, this is about 4 or 5 months into this process, as we look at the tissue thickness, this is good, chunky, thick tissue. This is good. This is very promising because the thickness of the soft tissue, therefore, the vehicle to bring blood supply into the area is going to be a positive thing for the bone underlying this situation. So at this point, we had adequate amount of bone to be able to place an implant. Again, a three-dimensional positioning is quite important. We will cover that shortly. One of the key things is we now know that we need to have good amount, 2 millimeters or more of facial thickness of the bone. Sometimes it's hard to grow the bone. So one strategy simply is to place the implant in a more palatable way. As you can clearly see, we have created from a tangential line to the adjacent teeth, there's about 2 millimeters or more of bone space. And of course, on top of that, we're gonna build more onto the facial surface. So second surgery, implant placement, and further grafting. As you can see, yet another non-resorbable membrane. And this time, this one has a titanium structure built into it so that we can force the space to be bigger, the space maintenance, one of the cardinal principles of guided bone regeneration. Primary closure is carefully done. And at this point, we keep our fingers crossed. We just hope that this will heal with minimal amount of volume change. And this is a comparison of the after the first surgery and after the second surgery. And again, fortunately, the cold tissue, the adjacent tissue, and the parallel ligaments seem to be holding up pretty well. So now our job is to uncover the implant, remove the membrane, and go from there. This is a very nice flat design, late Colmish design that he calls it the split finger design. I like it very much because it takes all of the tissue in that edentulous ridge area and literally pushes it laterally to give more soft tissue volume around the interproximal area. Membrane is removed. We verify that the bone is in fairly good condition, bone-like situation. We see that there's no gaps, no residual soft tissue, and then a nicely contoured provisional restoration is placed and has a beautiful contour. And this is actually what we now call the grooming stage. The grooming stage is where the soft tissue shape is going to be dictated by a few factors. The amount of soft tissue, the contour of the restoration, and how wide, how excessive, how steep the embrasure form is. And of course, now that the implant is strongly integrated, we can actually put a decent tooth on top of it so the patient doesn't have to wear removable denture anymore. So here you see the ideal space is created, and a surgical technique is to basically push all that soft tissue into that embrasure form and hopefully fill in so that the tiny black triangle disappears. And again, wishful thinking, keep your fingers crossed. And with passage of time, there's a little bit of a soft tissue scarring and dimpling, but we are starting to see the black triangle disappear. And eventually, soft tissue seems to be quite nicely matured. And now my job is done. And then the job of the restoring doctor, in this case, Dr. Kenneth Kim in downtown Los Angeles, performed a very, very meticulous work where he actually used a full zirconia abutment and a couple of ceramic restorations. This is actually on the day of the delivery. Very, very small, a tiny black triangle is evident. This is a 10-year-old case. This was the beginning of the situation. And this is pretty much on the day of the delivery in about a year later. And we she is very happy with the outcome. Me, of course, blowing up a image like this and looking at the black triangle, I'm hoping that that will disappear. Take a look very carefully. This is 2011. Give it a little bit of time. And by 2015, 4 years later, that little black triangle is almost gone. Remember, this is a very large screen, okay? This is a very large screen. In reality, it is almost unnoticeable in the patient's mouth. So we see that the bone and the periodontal ligament in particular is very stable and true to Dennis Tyler's earlier finding, if the distance from the contact to the crestal bone is, say, 5 millimeters or less, we have a pretty good assurance. And in this case, we actually are way under 5 millimeters. So we have almost a guaranteed situation. So let's share yet another case. This is a young, attractive woman, high smile line. The teeth have been traumatized due to a sporting accident again. And you can see signs of many of these anterior teeth with root foreshortening and heroic dentistry again with some endodontic therapy and whatnot. And tooth number 7, or 1, 2 in the international configuration, that upper right lateral incisor has gone to the point it's mobile, it is just not sustainable. So we are, faced with this dilemma. How do we restore this? And our strategy is to hold on to the teeth as best we can by carefully controlling the occlusion and whatnot. But this lateral incisor has to come out, unfortunately. You can tell by the gingival stippling the soft tissue health is quite great. She has great oral hygiene, and the key here is to not disturb the environment and just simply get the tooth out of there and immaculately replace that with something very similar in shape and size. So an immediate implant is clearly an advantage to our approach. The implant is placed appropriately, appropriate size abutment is placed right away, chair side. And this time was given help by Gianmarco O'Brien, one of the most talented restorative dentists in the area. He's a prosthodontist. And what he magically did, he took that extracted tooth and bonded it into the peak material provisional and made it into a screw retained restoration. The osteal shows extreme stability, and we do that by undersizing and densifying the bone as we place the implant. Now, whatever the residual gap that we have here needs to be grafted. There's no ifs and buts. Needs to be grafted. Otherwise, we are going to be facing a significant volumetric change. So this is what we're talking about. The gap, because the implant is placed palatally, there's always going to be a crescent-shaped facial deficiency, which is, in this case, we're using sticky bone and CGF to fill. Now, this is Dr. Thomas Hahn's beautiful article from 2009. Dr. Hahn is an amazing periodontist, my personal mentor. Everything I learned from this gentleman. So a crescent type of free graft is a meticulous shaped graft that can fill that void. Amazing technique. However, in my situation, we chose to do it with the sticky bone and the CGF PRF. This is pre-op. This is immediate post-op. You can see the same tooth went right back into that lateral incisor spot. And because of the dehydration, since the tooth was out of the mouth for quite some time, you can see that chalky appearance, only to come back to the natural state in 6 days. Take a look at the translucency, take a look at the gingival papilla, the gingival margin. And for the non-believers, there we go. There is a true access hole on the lingual, and the radiograph shows exactly that same tooth with the appropriate design going right back into that extraction socket. The patient was ecstatic because she was expecting a lot more traumatic issues. And then when she realized, gee, this is going well, she then asked for some further cosmetic enhancement. and that's beyond me. So again, the prosthontist got involved after careful diagnostics and treatment planning. Trying to get the midlines. You see, the teeth were all over the place in terms of sizes and the cant and the directions, and the prosthontist magically cleans all that up, straightens everything up, and with porcelain restorations, he was able to present beautifully symmetrical, translucent, just absolutely appealing restorations, and the radiograph shows exactly where that implant is. And this is the patient side by side, before and after. Again, is Dr. O'Brien in Orange County, California, who has done the magnificent work. And going up many years is just a just sparkling result that everybody is proud of. Next case will be Catherine. She's a little older woman. She's actually in her 70s, fighting a cancer at this point. When she presented, she was told by other clinicians she needed multiple implants. When I looked at her, I just didn't agree. We needed to do some occlusal therapy, some periodontal therapy, some of the class 5 restorations needed to be updated and so forth. But truly, that central was the only issue that I saw. Patient, right before I started the surgery, said, "Oh, by the way, I want this to look really good. I've heard that you can do that for me. And while you're at it, could you get rid of that dark stain?" And before I knew it, I said, "Sure." And then I said, "Oh my gosh, what did I promise her?" Well, let's take a look. In this case, the challenge was the tooth came out without a fight because, as you can see, the previous endodontic lesion and the surgical therapy made the tooth rather short with very limited support. So you can clearly see that the facial is collapsing. In other words, there's no bone there. So what I had to do, and of course I had to diligently do what the patient requested, which I promised her. So I said, okay, let's go after it. Let's go after the amalgam tattoo, and realizing the further you go in, it's like an iceberg. It's much bigger at the base, and I am just biting my tongue to say, why did I even start this? So the implant is placed palatal where the good bone is, and here is the implant position. And boy, by the time the osteotomy is done, not a whole lot of facial bone either. And by the time the soft tissue was cleaned out, so to speak, so that amalgam tattoo was gone, we had not much left. So the implant is now going in with a dehiscence, clear dehiscence, but my job now is to build that area up with significant amount of bone and soft tissue. So the same trick is being used over and over. The extracted tooth is carefully manipulated with a screw access hole towards the palatal. This time I did this myself. Sometimes I can do that. And, the temporary sleeve was attached. And to make sure that we don't have any unwanted material going into the surgical space, we tend to utilize the PTFE tape, what's better known at hardware stores as Teflon tape. And there are some good indications for this. People should know this. It has a very, very high melting point, so we can go into the autoclaves, but do not use it straight from a roll. That's not right. Do autoclave them. My staff rolls them up and puts them into autoclave bag. Other authors have shown different uses, and there are a number of articles written. And this, for instance, is what we used to do in the past. Cotton. I used to put some tetracycline in there just so that there is a little bit of a bacteriostatic effect, because tetracycline low dose does inhibit collagenase activity. But you know what? Two things have changed. Now that we use conical connections more, in my office, I just use conical connections, nothing else. When we do that, we really don't have a whole lot of space in the abutment implant connection. So there's not much of this, foul odor. But now that we use Teflon, Teflon is bacteriostatic in itself. So there are many advantages of using that. And this is a very widely known way. Now, some people like to use it for retraction cord. I think it works and I think it's great. I'm not a restorative dentist. I don't know much about that. People use it for insulating all sorts of different ways. This is a very, very good clinical example I found online. This is how I use it when we do surgical exposures, for instance, and we have to expose the area to, very strong chemicals such as acids. Then I like to protect certain periodontal ligament spaces and whatnot with this material. Works pretty well. Works. There are many, many indications. In this case, what I did was I took the temporary sleeve, the titanium sleeve, made a little poncho, and used that as a physical barrier so that this flowable resin like your material does not go into the surgical space where we do not want. The dual zone concept, the Stephen Chu and the NYU group's concept that's very well known. What is also important, and Todd Schomburg from UCLA talked about this in this beautiful article. What we need to do is we need to make sure that the embrasure, the transition, shouldn't have any bumps. This is from Todd's article. And here we need to get rid of that excessive flare so that we have maximum soft and hard tissue that can grow into that very intricate space. So here is a small little detail, but something that clinicians have to pay particular attention to. So there we have it. Oh, how do we manage this big wound? Massive amount of sticky bone. Did I use a membrane in a classic sense, collagen, or say a PTFE? No, I don't think it's necessary. So I've built up a very significant amount of bone, 2 layers, double layer, allograft as a deeper layer and xenograft on the outer layer that resist resorption. And you can see a good trick to making sure that the sticky bone doesn't sink into the implant connection is to leave some sort of a attachment. In this case, this is a smart peg from the ostial. And by the time bone is packed and very carefully removed, there is the virgin connection without any particles in it. And then you take this restoration that you have created, and before you do that, put a little apron on it, a poncho, this time with the concentrated growth factor, PRF, platelet-rich fibrin, whatever you want to call it, and take it to the mouse and carefully insert it so that this skirt, this drape of very strong concentration of growth factors is right there at the junction of the margin of the gingiva. So there we have it. And of course, the bigger wound at the facial was also covered with concentrated growth factors. This is exactly the way the patient walked out of the office. The key here is to try to preserve the interproximal bone, the periodontal ligament on the adjacent teeth, and try to grow as much facial bone as possible. This is something that I call the double poncho technique. Poncho technique was actually named by my good friend and collaborator, Dia Son from Korea. This is a variation of it. We use 2 different ponchos. One is the apron to block out the resin material, and one is the biological barrier that we use as we have shown, and we name that the double poncho technique. So as things heal, it's looking quite remarkable. One surgery, just one surgery, implant placement, grafting, and so on. Everything was done in one surgery. And several months later, now we're going through the same process of building this case up. And here is Ken Hines out of Southern California made this technique a popular one way back when. And this is my variation of it. It's an article from 2004 where we take the existing restoration. If the embrasure is good, then you want to replicate that in whatever form. You can use clear bite registration material, which is quite easy, and then duplicate that contour into a conventional impression coping. Even in today's digital world, we may take the impression with a digital intraoral scanner using a scan body, but I still have to take this, and the lab still needs this information because digital capabilities simply just cannot pick up this detail. Anyhow, in this case, this is done in an analog way. Mark Tillman from Spectrum Dental Lab did this work. Beautiful zirconia abutment and the screw retained, like a what we call the screw mented, screwed and cemented, and the contralateral tooth was prepped, and 2 teeth were delivered side by side. This is actually done by my wife, who is a restorative dentist, and here is the resulting outcome. fairly nice looking soft tissue. That dark amalgam tattoo is gone. Embrasive forms looks pretty decent. But the key thing here is everything fell right into the place because I did not make any mistakes in terms of key principles. And this is the way the patient presents about 4 years later, extremely happy. Oh, unfortunately, Catherine is fighting a cancer right now, but she is extremely happy with the outcome. What you see on the CT scan, this is where the bare threads were exposed on the time of the surgery. But look at all that bone that's still there. And what is also key here is this circular darkness, which is what our good friend Scott Gans has introduced many years ago. The good old cotton roll technique. The cotton roll, put the cotton roll in the mouth to be able to lift the lip out so that we can tell where the soft tissue, namely the gingiva, is, as opposed to where the lip is. We can actually visualize the extent of the gingival complex that we value so much. This case was actually published in this textbook in India. I don't know if it's available in the United States yet, but the key author here is my good old friend Lanka Maharsh from New Delhi, and Craig Mish and David Schwartz. All of these gentlemen contributed, many others did, but this particular case has been added to this textbook. So we talked a lot about embrasive form, the emergence profile, and how the physiological architecture, that's the important part because natural teeth need that physiological architecture for health and function. It is even more important around dental implant. If we arbitrarily ignore that, or should I use the word abuse that in this case, zirconia implants are great. We clearly know that they have more biological aptness and friendliness. But in this case, it was a poorly executed case of a, well, I don't know how to describe it. Where the embrasure should be more soft and hard tissue ought to be. This particular design, we did the reverse. There was more zirconia, more material, and therefore the patient ended up with this unideal situation. And the only way, to rectify this was to get the implant done. It's a one-piece implant, for goodness sake. So, the only way I could get that out was to, screw that out. The other one I was unable to. So we were able to take one implant out. It's just good material, good implant, but just poorly executed. So, summary. For implants, any implants, let alone the anterior aesthetic area, these are, at the end of the day, the things you need. You see, just like a luxurious car, if I have a Lexus that goes to the Lexus dealer, they want to make sure that all the checklist is given before the car is released back to you. If you are a pilot of an aircraft, of course, you're going to go through the checklist to make sure that the plane is going to be flying safely. So this I do at the end of the procedure. When the case is completed, I want to make sure these 12 essential points are hit. Anyway, for the sake of time, let's just focus on the first three, what I call the three rule of twos. The first one is facial bone needs to be 2 millimeters or more. But that's unfair because on natural teeth, 2/3 of natural teeth don't even have a millimeter of bone. That's been shown by a variety of recent findings. 1 millimeter at the most, but we want the implant to have two. Wow, that's an unfair situation, but we just need to know how to do that. Bob Spray and his group talked about this number earlier on. So this is a very well established. We need 2 millimeters. Let me share some early mistakes that I've made. This is Craig. Craig comes in with an unrestorable upper right central. The restoring dentist sent in this partial denture. The tooth was removed, and then the implant was placed. This was almost more than 10 years ago, 15 years ago even. And then, external hex. I haven't placed an external hex ever since 2003, so you can see how old this case is. So it goes in, the surrounding area graft is done. And similar principle, I want to hold that soft tissue structure the best we can. So we make a custom healing abutment that preserves that and supports that delicate structure. And the partial denture was placed over it without any direct load. So that's an optical illusion. It looks like it's touching, but it's not. Therefore, the implant integrates without much interference, but the soft tissue, there's hardly any changes. And at 4 months, soft tissue is preserved the best we can. And you can see that the implant is now ready to be restored. Is there some resorption? Yes, there is slight flattening of the facial surface, as you can imagine. And then we go through the standard duplicating custom impression technique. We've seen that. As we do that, and this is again, this case was actually published in the compendium. Now, this gentleman comes from fast forward 20 years. He's now in for, boy, class 3 occlusion, more implants done gradually. And that same implant from 20 years ago, you realize there's no buccal bone. There is no buccal bone. My mistake. I should have placed the implant more lingually, let alone I should have put some grafting. So this is yet another case that I did with the same protocol. This is a case that was published in a Korean textbook in 2003, virtually the same protocol. And I said, this looks really good. And I was very proud of myself in 2003 when this book was published. In 2002, that's when the case was completed, and it was published in 2003. But let me just fast forward this. This is something very similar, so I'm just going to fast forward to December of 2010. So this is about 8-year follow-up. She's actually still in my office. But 8 years follow-up, when you see this, everything parameters look good. If we do the aesthetic score, they ain't too bad. The white aesthetic score, the pink aesthetic score, doesn't look too bad. But if you look very carefully right there, you can almost see that titanium through. In other words, at that time, I was not aware of this fact, and I should have placed the implant a little bit more lingually and or grafted the facial a little bit more aggressively. So very, very thin amount of facial bone, eventually 8 years later, it's gone. So thickness of the soft tissue is equally important. Thomas Linkivicus, our good friend from Lithuania, he has done some extensive work on this, and I'm very, very proud of him and his latest publication, an exceptionally good book. I highly recommend everybody read that. Now, one thing I have with him is I was giving this lecture in Australia last year, and I said we need 2 millimeters. And that morning he posted something that said, no, we need 3. So now we have to change this to 3 millimeters soft tissue that's needed, and that's a new development. Just a quick note on this. An interesting article that everybody should look into is this 2006 article from the Japanese group. What they had done, they had taken finished restorations, and they have 1 or more year, and then they took the restorations off, took the study models, and they actually measured the soft tissue dimension, what I'm going to call, just for argument's sake, biological width and biological height. And they looked at that relationship, and they came up with this odd ratio. The point here is you need to have a very wide base for the height to be there. Without the base, you cannot have the height. So soft tissue volume is important, but also equally the embrasure, having the right contour to allow the soft tissue to coexist is equally important. So having a right embrasure form of the restoration and having the right ratio of tissue and increasing the volume right there at the base is pretty much the strategy. This is a paper that my group published when I was still with UCLA. And this is a collaboration between Seoul National University from Korea. This is a whole periodontal group. A couple of these guys went on to become the deans of the school. In this paper, we reported 10 patients, 11 implants, all immediate implants in the anterior region. But the protocol was to do the immediate implant placement, graft of bone, and connective tissue graft, as you can see in the diagram here. And we did a 2-year follow-up. We measured all the parameters of soft tissue, shape, size, and keratinized tissue and whatnot. And basically, the conclusion is that doing connective tissue graft concurrently with the bone graft is one of the most predictable ways of handling this anterior situation. So that's a paper from almost 10 years ago. So the third aspect of this anterior rule of twos is the amount of keratinized gingiva. I think at this point, we do not need to have an academic debate as to how much keratinized tissue is, needed around teeth and or implants. And the verdict is out. To me, 2 millimeters or more of keratinized tissue is a must. Otherwise, we're not going to get the sustained health. This is a good example. A case that was recently completed in my local area. Not bad, perhaps arguably maybe the first thread is involved. We can argue, but this type of implant, that's a normal appearance. But what is the problem is this patient cannot chew because the patient has pain. Patients simply can't brush, can't chew because of the pain. And as you look at this area very carefully, there is lack of attached keratinized tissue, the natural barrier. So this is a very straightforward, simple therapy. I did a free gingival graft, but I actually call it the expensive graft. Okay, expect some laughter in a crowded room, but in a webinar, that's a little hard to do. So, gingival graft, free gingival graft, or what I should say, freed graft from the palate. And in doing so, look at the immediate result. This is not more than, say, 2 months later. Now the patient is able to chew and function again, brush the area, eat on chunky food and crispy food, and life goes on. The seal effect is so important around each and every implant. Here's a problematic implant. In California, I don't know about elsewhere, we've got a lot of attorneys who don't mind taking on a patient who's not happy with the dentist. This was a legal mess. Anyhow, when you look at the facial aspect, this is inflammation. Again, what's the issue? Not having the barrier effect. So I retreated this rather, removed the implant, grafted. Long story short, at the end of this process, the protocol, free gingival graft is part of the treatment plan. And in doing so, finally, I am able to get this nice seal effect so that this implant can go on. Okay, so I've mentioned this several times, but implant positioning is a very, very common mistake most of us make. Lessons I have learned. Okay, I'm not very proud of this case, but let's share this for the sake of sharing it. We went through a period of time in the early 2000s. This is about 2003, 2002, I would presume. And we were sort of led to believe that gigantic implants were not a bad idea. Oh, this is a 2001. I can't lie. There's a date right there, old Ectochrome. And, I wouldn't do this today. But at that point of time, it was a fairly common thing. And many people said, yeah, the anterior central incisor is roughly 5 or 6 millimeters in terms of the root diameter. So why not put in a 5 or 6 millimeter implant? And we went along with that. Looking back, that's not a great idea. You see, we know that when teeth, implants, or any teeth structure are facially charged, then we lose gingiva. This is yet another case. This is a mistake that I've made where I placed two implants using the conventional surgical guides, and I thought I did a decent job. But you can clearly see, arguably, this one's okay, but this one's too far facial. I just didn't see that at that time. And as a result, we get this gradual recession on the facial surface and not the best result of the facial tissue. And, 12 years later, just doesn't look as good. So that's an issue. Luckily, the patient doesn't mind and she loves her teeth, so I lucked out on this one. Beautiful lady, beautiful teeth. So, placed implants palatally. I think that's the most easiest strategy that we can all use. And by instead of having a mid-crestal, we need or facial, the palatal approach always gives us that safeguard. And Willie Grunder's paper talks about this, but I think we should be able to place it with more of a cingulum access and more facial bone. I think that's the way we should be going. So this is a good example of how to palatally place implants. Palatal. This is a good trick that we can use, a figure of 8 that can tell us whether that implant is in a good position or not. Second strategy we can use a smaller diameter. You just saw that case with the 5.6 millimeter old implant. That's just not the right thing. Use the smallest diameter that is strong for the job. So you can clearly see graphically place an implant that's small so that it allows more facial space, and place the implant deeper. This could be a controversial topic, but I think the jury's out on this one. There's enough evidence to say if the implant is of a conical type connection, which is a lot more sturdier than flat to flat butt joints, then you are able to place the implants fairly deep. Here's an example. This is an Astra, but this is one of many that fall into that category. Astra, Straumann Bone Level, Ankylos, Dentist, many of the Korean implant series with a similar Astra compatible type of connections all behave in pretty much the same way, a good way. And that is, in this case, the patient was unsure as to what she wanted to do. So I grafted this area not knowing what the outcome will be. She has concurrent parallel disease that we're fighting with. And then ultimately she said, I do want to go through with the implant. So I said, okay, well, then let's place the implant. Because of the circumstances, I placed a fairly short implant, a 9 millimeter implant. And as the case is being worked up, a provisional goes in, and you can see that bone is gradually getting calcified and healing is taking place. And by the time 2 years later, the restoration was placed and maintained, you can see tremendous amount of supracrestal bone that we didn't have before because that implant was placed right at the bone level. It was not placed deep at all. It's hard to explain why this happened, but I guess as the parallel disease resolved, the body decided to grow extra bone that's completely unexpected. And 6 years later, 9 years later, 12 years later, she is extremely stable with that extra bone. And if this was the old, let's say, Brennemark type or internal hex, or God forbid, the trilobe type of not as robust connection, we would have lost all of that bone. But because it's a conical robust connection, it seems to stay 12 years later. And you can imagine the amount of mechanical stress that we have there. So the best strategy on preserving things in today's world, contemporary world, there are different methods. And let's talk about several of these. This woman comes in, young lady, significant amount of resorption. Didn't have a choice. The tooth had to come out. You can see that resorption in many of these radiographs. So for her, she wanted this to be nothing, less than perfect smile. Because look, she spent such amount of money on the restorations and she really values her aesthetics. So my proposal to her was this newest technique where we leave a little bit of the tooth root on the facial surface, what some would like to call the root membrane technique, the socket shield technique, whatever you want to call it. It is a strategy to try to hold on to the facial gingival structure. Here, my challenge was I really had to be sure that all of the diseased resorptive process in the pulpal chamber had to be completely removed. I'm saving the tooth, by the way, you know where this is going to go. And then that very, very thin facial bone is preserved and not, it needs to be shaved down deep enough so that it is not going to communicate through the gingival sulcus later on. In this case, it is even more important to get the implant on the palatal side. And I truly believe the gap has to be left there so we can fill that void. I did use a scalloped implant or a angled implant for a slightly lesser, deeper embracing on the facial. You know what this Teflon material is now. Pick up, contour, and that little piece of the bone is what I believe is holding up that facial area. 2 months healing, I was getting a little nervous because she was swelling up, and I said, "Oh, did that piece of the root break? Is it moving?" Well, the fact is, she got pregnant. So this was more of a pregnancy-related inflammation. And once everything was said and done, this is about a year later because of a pregnancy. Now the restoration is being done. This actually restoration was done by Michael Chan in my area. Beautiful outcome. Take a look at that facial tissue. Absolutely no change. And this is about 2 years later. So socket shield, root membrane, I think those are all great terms. Partial extraction therapy. I like the term root banking. It's kind of like, I think when we communicate with the patients get this one really well. Let's do what's called root banking. I leave a piece of the root of the tooth still in the mouth. And people say, what? What are you going to do? Yes, we leave that deliberately, but we do that because it's going to hold up the shape, and we call it root banking, just like you bank money in a piggy. So that's a concept that's, I believe, easier to taught, my opinion. Take a look at this case where we tried very hard with the prosthodontist, the endodontist, everybody on the team to try to save these two teeth, and eventually implant had to be the answer. So for this one, on that central, I've decided to leave this crescent shape. And this is an interesting one because this one actually shows where that very, very small piece of the bone is. Depending on the light, yep, you can see that it's really thin, but that's going to be the key to what's going to hold up that facial contour. Take a look right there, very small piece of the tooth, and that is the key to what is going to hold up that very, very delicate facial surface. Okay, let's talk about this more extensive case. This lady comes in. She needs extensive work. She's had this crippled dental situation for quite some time. She had to send her son to in college and school. And when that was all done, she said, "It's my turn to come in and get my work done." She is desiring to have good, healthy mouths and a better smile. Partial edentialism. There are a number of teeth that are not restorable, diminished vertical dimension. So these are all the things we had to tackle. Not to mention her expectation was a little bit high. In this anterior zone, the treatment plan was to place two implants and have four-unit bridge with two ovate pontics in the central. Pretty standard type of a foolproof treatment planning, but devil's in the detail. We have to make sure that every little detail is executed without mistakes. Back when I was a resident, I ran into this article, Burton Langer's article, what's called a spontaneous in situ gingival augmentation. And I've done a few of these cases, and I said, this is an ideal case. So what it is, while the patient is wearing the provisional restoration, I go in and burr out the crown right to the crestal bone level. And this is Burton Langer's original 1994 article. And this was done so that when immediate implants were being done, which was, right at the beginning stages of that treatment protocol, we wanted a little extra soft tissue. So by removing, by cutting the tooth, or what we call coronating, the soft tissue grows over the ridge, and we utilize that extra soft tissue for our next agenda. So take a look. The teeth were filed down, the two centrals, the pontics. Of course, the laterals were used as support, as tooth abutments. And this is about, I believe, 4 weeks later. When you take the provisionals off, you get good amount of tissue. Now, the mistake I made was I wasn't aggressive enough, and when you're not, you can see that really slender piece of the tooth still there. Then it inhibits the soft tissue growth. So that was my mistake. And you can see the sharp edge of that tooth on the facial surface, which I didn't see. Now, you could potentially end up with the same problem when you do the root membrane technique. In this case, I had, flat, because we're now replacing the implants. I had flattened that sharp edges, and then we are going to bury those roots. Root submergence technique, yet another variation of this partial extraction therapy genre. So here, as you can see, I've added a little extra layer of xenograft on the facial surface to plump up the tissue. We've created this ovate pontic environment. And now, together with the sinus lifts and so many other implant restorations and whatnot, there is the ovate pontic shape that is being ovate site that's being developed. And fast forward, this is the before and the after. So something as simple as that, and by plumping up the facial aspect, we're able to get much better lip support. No more need for Botox in this case because we've actually physically changed the outcome. Slight increase in the vertical dimension of occlusion also helped flatten that nasolabial fold. She was extremely happy with the result. These are the types of patients that send you more patients, her friends and family. So I've benefited from that sort of a referral and her excitement. You can see that the vertical height was raised, and this was actually, I have to give credit to Dr. Swati in my area. But here's the thing. Here is the two roots. They were endodontically treated, so that was great. And they're buried underneath. And that is the key as to how we are able to maintain this volume of tissue. And they're buried deep enough so that we don't ever have to worry about them causing secondary problems down the road. Marie Salama and their group wrote about this root submergence technique, RST, a while back. So I've introduced quite a few different types of tricks in the given time. Sort of a afterthought. This young lady, Dr. Ellen O, brilliant student. She's a brilliant clinician, and now I have the honor of working with her in my practice. When she was a student, she used to do a lot of research project with me, as you can see some of these results that we produced. And one of them was this one, incidence of implant complications from my own practice. All the implants done in a span of 10 years, and then we followed up on the data. And here's the thing. Yes, I do get abutment fracture, screw fracture, neurosensory issues, occlusal issues, systemic problems, smoking, all of these, routine problems in relatively small numbers. Periimplantitis is a big one. Soft tissue problems is my number one besides periodontitis. So although I try to practice with a high bar, being a periodontist and somebody who has a little bit of a passion for soft tissue, I give it all I've got. But still, soft tissue is, in the end, the biggest issue. So we need to truly have some techniques to be able to handle soft tissue very well. Along the same line of this insight to augmentation, let's take a look at this case. This is a case that I thought was a slam dunk. A single tooth, good soft tissue, everything seems fine. When the tooth was removed, I noticed that the buccal plate was a little weaker than I thought. Sure, so let's watch that out. Implant is placed in the palatal direction. Everything is nothing new here. We took the extracted tooth, put it in this Essex appliance, and fast forward, just case just did not turn out right. I didn't get that bone preservation. Um, so it's just not, it's a failure. So I am trying my best with the lab to say, can we do this? Can we do that? Can we try to get the soft tissue to grow back? Everything did not work. So we've tried multiple times, different abutments, different shapes, different materials. Nothing worked. So in the end, this is what I had to resort to. Remember the Langer technique, 1994 technique, where you cut the tooth, decoronate down to the bone level. And this is one of my cases, treated in 1996 when I was still a resident. Here, okay, the central incisor had gingival margin much higher than the contralateral one. So we actually did Langer technique. Cut the tooth off, just let it be. This guy's a stuntman in Hollywood. And when I told him you shouldn't be wearing a partial denture, he goes, nope, I'd look more cooler. I'll get more jobs and more additions this way. So he walked around without a tooth. And in doing so, soft tissue grew, which is great. And eventually when the implant was done, not the perfect result, but we got better soft tissue than the beginning. Thomas Hahn and Tom Lee from UCLA helped me with this case. Tom Hahn helped me with the surgery. Tom Lee did the restoration in 1996. So fast forward, this is many, many moons later. Stephen Chu and Tanau's group talked about similar thing around dental implants. And this is one of their beautiful cases where implant with lack of soft tissue, they basically took the crown off, put a cover screw in, put a provisional bridge, and eventually soft tissue grows in, and a new implant restoration was made. So that was their article from 2013. So I said, times are desperate. This is where I need to do something like this. The screw retain restoration was removed, and the soft tissue let to grow freely. In situ soft tissue augmentation. In 6 weeks, there we go. We've got decent amount of closure. And at that time, I am doing sort of a second stage surgery, kind of like old Lenny Abrams' roll technique. Go to the palatal side, bring the tissue. Be very careful because there's always this little pinhole right in the center, not John Child's pinhole. This is a pinhole that's remnant of the original implant space. And the tissue is rolled to the facial, And this is a material called FibroGuide. Glycic makes this, and it's a beautiful material because the reason I had to resort to this one is the patient was tired of grafts because I have attempted connective tissue graft, free graft, and the patient was tired of getting tissue taken from the roof of the mouth. So I resorted to the fibro guide, a small little piece which is packed into that facial surface. The soft tissue is tucked in, just fancy sutures, and we are able to recover what was lost by using this approach. This was done immediately before the lockdown happened. I hope that tissue is healing perfectly. I have not been able to check on this gentleman as of late. So there we have it. Within this time limit, I've tried to share what I know about this so-called magic we can do. Um, if you are people in the Southern California area, please join me in my study club, which is part of the Seattle Study Club, the West Coast Study Club. Because of the situation, we've gone to the online, and we will open up this next meeting in May to non-members also, but only the California dentists. I'm sorry about that. We have to restrict it because so many people signed up last time. When it comes to soft tissue, you really need to master the soft tissue when you want to deal with the anterior implants. And John Chow, with the pinhole technique, not necessarily around implants, but in general, you learn a lot of good concepts. Pat Allen, he's my teacher. I learned a lot of tricks from this gentleman, one of the best soft tissue surgeons and one of the incredible teachers out there. I have created, I believe, one and only soft tissue surgery program on live patients through our group, GDIA. And it is an amazing, fun group. We go down to Tijuana, Mexico, which is less than 2 hours drive from my house. We do that on a very regular basis. We have just graduated just over 400 doctors from all over the world. And this was our very last program that we did before the shutdown, where people go down. We actually did fibro guide, we did connective tissue graft, free gingival graft around dental implants and natural teeth. A great, great fun group. And watch out for this group. They put on a lot of educational material, gdia.com. This afternoon, Jill Park, one of my dear students, she actually took our course. She then went on to become an amazing clinician, and now she starts to teach with us. She'll actually do a webinar this afternoon at 2 p.m. California time. There's only a limit of 500, and as of a couple of days ago, we have about 400 and 80, 90 signed up. So if you can get a space, I would highly recommend it. It's a great, great webinar she's going to give today. Thank you very much. I am honored to be part of this group, and here's my email contact just in case. And I promise you, if I meet any of you guys after this lockdown is done, I'm gonna come hug you guys and buy you a beer. So that's my promise. I think we have a little bit of time to answer some questions. So I'm going to let the host guide me with the next step.
Thank you so much, sir, for the wonderful session you took, as well as the cases you've presented. They are all quite stunning. And it was quite lovable that how you respect your teacher who guided you. Moreover, Dr. John was actually with us for the session yesterday, and he has been an amazing person, seriously. And so with that, we'll move on to the questionnaire.
Are you going to read out the questions for me, or should I do that?
So we have the questions for you.
Okay, I'm gonna, without getting my eyes strained, I'm gonna try to go through the questions the best I can. The first one that comes to mind is root piece that can be left in there. Can it cause infections or hindrance? Yeah, let me tell you a good example. If you're gonna do this root membrane socket shield, learn the proper method. There are some gurus in this. There are some authorities on this. Howie Gluckman from South Africa, Dr. Paul, Croatia. These are some of the people who are at the forefront. Isaac Towell. These are the people you need to learn this from, because if you do a copycat, you just see something on Instagram and say, I'll go do that. Yes, there could be some issues and consequences. One case that I did, For instance, it was done fairly well, but I did not remember. It was a bicuspid, and there was a root membrane. She went into the general dentist, and the hygienist went for the kill. She meant good. She wanted to clean the area very thoroughly. And immediately after the hygiene visit, the patient ended up with an acute abscess. And the patient remembered the hygienist saying, "There's something in there. I really need to get that out." So it sounds like she was digging in, aiming for the root piece. Now, when the patient called and said, "I need to come in because my gums are swollen," it didn't register. I said, "Okay, I'll take a look." And then when she came in, I said, "Oh, wait a minute, that's the case with the PT." So then I had a talk with the other team, the other hygienist. This is from a different office. So that communication is vital. And then the patient herself said, "Yeah, that's right. You told me there's a piece of root in there. I should have warned the hygienist." So those are the kind of things we need to. Now, I have root submergence case that, yes, indeed, there was a microfracture, I guess, and I didn't see that. And eventually secondary inflammation, and would actually go out and extract it. Those kind of things do happen from time to time. Let's see.
So, shall I spell all the questions?
Could you
That will be
please? Yeah, it's
comfortable for
really
you.
hard for me to. Yeah, it's hard for me to read through.
Yeah, definitely, sir. So, the question is from Dr. Gulzar. What technique was used to remove the amalgam tattoo?
Oh, amalgam tattoo is typically, as I mentioned earlier, smaller on the surface, wider at the base. Why? Because the majority of the material is engulfed, the phagocytosed by the cell layers, and they're typically giant cells or macrophages, multinucleate cells, right at the base. In other words, right at the junction, periosteum between the bone and the soft tissue. In other words, you're not going to be able to remove the bulk of the amalgam tattoo on the surface. You have to get down to the bone level. So there are several methods. You can use laser. You can use a coarse diamond rotary type of a burr. But in cases like the case you saw, because I was already raising a flap, we were in the middle of the surgery, so it was a careful manipulation with a traditional blade, filleting and cutting things away until, the visibility was sure that everything was gone.
Okay. So, the next question is from Dr. Suraj. Sir, is it possible to place a healing screw in this anterior girl case? Healing screw will also lead to good healing and less surgical intervention again.
I didn't quite get the question, but I guess the question is, can you do place healing abutments in these types of surgeries rather than say
Healing screws.
yeah, rather than say a provisional. Yes and no. Here's the thing: if you place a standard healing abutment, which is circular, and let's assume that the implant is in a good position, now the soft tissue will heal to that circular configuration. At some point, you have to introduce trauma. You have to change that configuration into the embrasure form, which is more of a triangular, very, very complex three-dimensional shape. You can choose to do that via surgery. You choose to do that by sculpting. You can choose to do that by gradual grooming with the restoration at some point. But that's too much work. And once the soft tissue is established, you do not want to disturb it as much as possible. So my first go-to is to make a provisional of the right shape. And if I do not want to have the provisional all the way to the incisal edge for possible interference of the osseointegration, then cut it short right at the gingival margin, like you saw in a couple of these cases. But having a customized healing abutment that dictates the embrasure form is the key.
Okay. Then we have again the question from Dr. Suraj. Please, sir, any tips and guidance for lower anterior implant placement?
Oh boy, how much time do you want for that? I usually
So
like to
just
do a
briefly,
whole,
just briefly.
yes, whole session on the anterior implants because they're number one, technically very challenging. We do have implants in the vicinity of 3 millimeters, 3.2, 3.3, and so on, but they are still not small enough. So we do need to have this size discrepancy where the spaces are small, the tissue is very delicate, and the embrasure form never turns out ideal. So that's one challenge. But let me just throw a fundamental philosophical question. Why are we doing a single tooth implant in the lower incisor? Many times, if it's fractured, if it's an endodontic failure, and so on, yes, we don't have a choice but to tackle it. I am not very excited about doing lower incisor, especially single. I try to do bonded bridges or conventional bridges for that reason. But periodontally speaking, the lower incisors are the last teeth to leave a patient's mouth. Let's face it, that's what the longitudinal studies in periodontal literature shows clearly. Upper molars go, lower molars go, upper bicuspids go, lower bicuspids go, upper anteriors go, and then the lower six tend to stay. That's why we have what's known as Keller syndrome or combination syndrome. We have a lot of patients wearing full denture on the top and a partial denture bilateral free and saddle on the bottom with the lower six teeth intact. In other words, the lower teeth do not part very easily. So, for instance, if something happens, and again, barred from trauma or things like that, if the lower teeth are loose, don't just assume they need to come out. There's some occlusal discrepancy, parallel issues. Treat that and treat that well, and you should be able to avoid dental implants in that area as much as possible. Again, that's the best answer I can give you because that is a half a day program just talking about this whole philosophy and concept. So I'm sorry, but that's the best I can do. Next question.
Sorry, sir. Yeah. So the next question we have is, why do you use allografts and xenografts at the same time?
Oh, that's a very good question too. Um, there will be a webinar that I will be giving in roughly 2 weeks on that very topic with GDIA and with Maxius, which is a bone harvesting bone tissue bank in the United States. Allografts are not readily available in different countries around the world, but in the United States, where we have it readily available, it is the best material. It is economical. It does turn into bone very well. So there's, not a lot of negative reasons to not use it. So allografts, to me, my go-to. Mineralized allograft, not demineralized, mineralized. And there's a lot of debate about cortical cancellous particle size, but put all that aside, mineralized allograft, because within the time frame that we're working, 3 6 months or so, it does turn around and give adequate amount of autologous bone in that timeline. Now, today, as we create the sticky bone out of it, in other words, we add platelet concentrate into that, that's even much better. But allografts do turn around and do resorb. So xenograft, which has been used extensively in Europe, namely Bioas and the likes, that has been the case in that part of the world. But the downside of xenograft is that it doesn't turn around fast enough. That's why Bioas, for instance, comes out with Bioas collagen, which is basically some collagen material added to enhance that turnover. So we're doing something like that. This is a layering technique when we do GBR. Sometimes in very large areas, we place allograft on the inside so it can turn around faster, but a layer of xenograft on the outer layer so that it can resist resorption and hold up the bone volume better. That's a fairly common way. Daniel Bruce's group in Bern calls that somewhat of a contour graft. Humley Wang calls it a sandwich graft. I mean, not exactly the same thing, but that concept is there. So it's kind of a variation of that philosophy where you want to put more biologically inert, more friendly material on the inside and less on the outside, mainly for volume control.
Okay. Thank you, sir. Next, we have from Dr. Miten. Can you use autoclaved Teflon tape as non-resorbable membrane?
I've never done that, but I think is scientifically plausible. If you know the history of GBR, GBR was an afterthought after GTR, guided tissue regeneration, was the first attempt, and guided bone regeneration is a later variation of that. If you want to know what was used historically, millipores. These are filters used in labs, medical labs, and then dental rubber dam material, rubber. So can you use Teflon material? And the answer is it is plausible in theory. Would you use it? I don't know if FDA will allow that. It is not medical grade. It is not designed to be put in the mouth. There's a reason why a company goes through all this effort to make sure that the federal, the FDA, Food and Drug Administration, in different parts of the world have something similar, and they assess the safety of it. So we got to be careful with that one.
Okay. Dr. Gulzar asks actually, he says that Dr. Zucchelli says that you need to place broader implants as the narrow ones have a greater chance of breakage in case they fail. And what is your take on that?
Well, that's an absolutely good statement. Implants that are thinner have certain appeals, but their strength is compromised. So, absolutely, Dr. Zucchelli's statement is absolutely correct. So, how thin can you go? Let's say a 3.5 millimeter as a central incisor, and for a maxillary central incisor. Certain brands are not going to be strong enough. They will have what's known as a flowering effect, where the crestal portion pops and cracks. So you need to have an implant system that is robust and strong. Now, I'm not going to go into different types of implant systems. This is not the forum for that, but you need to know your system well. You need to know what stress level, tensile strengths, and so forth it can withstand for that purpose, and you have to choose to implant very carefully.
Okay. So next we have from Dr. Gulzar, what technique did you use to decontaminate the implant surfaces in those cases from the past with complications later on?
Oh, implants, I take it as a peri-implantitis case because, when you're placing the implants, you're clearly not going to decontaminate them. But if it's an implant loss that's been exposed, I understand the question to be. That being the case, there's really physical, mechanical, chemical, and laser. Those are the three known methods to decontaminate. Which is the best? I honestly think laser is about the only answer. I've done a lot of plasty. I've done desperate acts where you go in and strip and polish off the threads in certain cases where we're trying our best to save the implants. Do they work? Limited, success with those kind of cases. But laser seems to be the best remedy. Not all lasers are created equal. We're talking about more of a Nd:YAG or erbium YAG. Diodes do not go there. Diodes are very dangerous because they generate heat, and on the metal, it will be nothing but trouble. So, certain types of protocols are in place, and follow the literature, follow the devices very carefully on that one.
Okay. So I think we are not having much questions now. But I have a question for you.
Sure.
Since this series of amazing speakers we have been listening to, so I've heard like one of the speaker told us about airbrush, the use of airbrush for the cleaning of the implant surfaces. So what about your view on this?
Yes. Again, with limited time, I can only say so much. How do we maintain and clean implants is a very, very broad and deep topic, but in a few minutes. Mechanical, if necessary. There is not a good reason to start digging into the sulci and disturb the very delicate attachment for no reason. But if there is deposit, yes, you have to go after it. In other words, whether it's by air polishing, and we're talking about, certain biocompatible materials that can actually go in, and even if you leave the residue behind, it has to dissolve away. That's what we're talking about. Or mechanical devices such as curettes. Now, there's a lot of things out there which don't make any sense to me. For instance, there are plastic curettes. Supposedly, the argument is plastic curettes do not harm the implant surface. I think that is a baloney argument because plastic surface materials do not remove the debris adequately, and in fact, it leaves residues behind. When you use ultrasonic devices, some people advocate putting a silicone cover so that the metal doesn't have direct contact. I think that's just a very wrong approach. Why are you even going down there? Because we want to remove debris that's not welcome there. There will be some collateral damage. So use metal. But if you use silicone, you are going to leave residues, not, but at the same time, not be effective in cleaning out the debris. So, again, this is yet another very large topic, but this is not well understood as far as I'm concerned. So there are three types of maintenance patients. Let's just go through that one by one. The first type of maintenance patient is people who do not have debris down there. Just keep up the oral hygiene. Encourage them, send them away. Second group, these are the people that actually have debris down there. But the object is to get down there, remove the debris the best we can with minimal damage, minimal side effects, and then life goes on. Okay. The third group are the people that have serious periimplantitis that require intervention. We might be talking about surgical intervention. We might be talking about removing of the implant, but that's a completely different group. So those are the three groups. So where do you use these other instruments? I don't know. Do we use air polishing? Yes. Do we use irrigation with sodium hypochlorite? We do that routinely. We want people to use things such as water pick with a 20-to-1 dilution of household bleach. Right now, bleach is hard to find because everybody wants to use bleach to fight the coronavirus. But patients who are in that second group, the second group who tend to get material and the sulcis are deeper, not as ideal, we recommend people use because, the air polishing can only be done at dental offices, but water rinsing with bleach at home is what they need to do on a routine basis. Once a week, twice a week is what I recommend for people depending on the severity. I hope that helps.
Okay, rinsing with bleach. You're talking about that?
Yes. Yes. When you first talk to the patients about that, patients like roll their eyes and say, "What are you talking about?"
Actually,
And
actually.
and then we have, this is my usual comeback. Yes, you heard me right. I want you to use bleach, diluted bleach, and rinse your mouth with it and get that implant area clean because you made an investment. And if you had coronavirus, would you not use a strong material like bleach? If you have dirt on the kitchen floor or your bathroom or your underwear, even I sometimes use that word, dirty underwear. Why do we use bleach? Because it kills the bacteria and the germs. You got the same type of problem in your mouth, therefore you have to use the bleach. And sometimes it just wakes people up. Many people are in denial. They just don't know the severity of their periodontal disease slash periimplantitis, and sometimes that wakes them up. So that's a very good communication tool as well.
Okay, so bleaching agents you suggest for the implant surface, like the surroundings clean, right? And to prevent periimplantitis or periodontal
Correct.
diseases. Correct. So, okay, do you suggest those
Correct.
for pericoronitis as well?
Oh, pericoronitis. Yes, if it's if it's a tooth that cannot be removed. I mean, pericoronitis. Uh, remove the tissue around it, a pericolectomy, or perform an extraction. But if it's something that's not feasible, then bleach, diluted bleach. But you got to deliver. If you swish passively, it's not going to work. You need to have a device such as a water pick that positively forces that fluid into that tight space. If people need more material on this, because people say, "What are we talking about? Never heard of that before." There's a lot of literature behind this. Please email me. My email is right there, and I will email back this kind of data handouts that you can use for patients that I use in my own office. I'll be more than happy to share those.
Definitely, sir. That was quite amusing to listen that using bleach agents, that too for our periodontal disease. That was quite amazing to hear from you. So, with this, thank you so much, sir, for the wonderful session, and thank you for the query solving itself. And it was quite amazing to listen from you.
Thank you very much. It was my pleasure, and I hope everybody stays safe and get ready to get back out there, provide the best quality care for our patients, and hopefully we'll meet each other one of these days. Thank you.
Definitely, sir. Stay safe. You too also. So with this, I would like to commence this session, and I would like to inform all the participants that for the C certifications, for the participation certifications, as well as the speaker's schedule, you all can log into www.gomha.org. And with this, I would like to end upon the session. And we are having a lot of more beautiful speakers lined up with us. So stay tuned. Thank you so much, sir. Thank you so much.